James Yee, and my name's Darren Walters, Alan Young, and a very distinguished panel here. You've got an interesting case for us, and perhaps you're going to update us on outcomes in Bonn.
Yes.
Tell us all about your case this morning.
So we followed, and congratulations from our side too. Great case with a wonderful result. So now here we have an interesting situation, and maybe Dr. Ahn, you know, before I go into the details here, I almost feel at home, I have to say. It's the room that I used to work in with him. This is where I proctored, and only the top ones get the big hybrid room. So we are the PRs today, and we have quite an interesting case. Thank you very much for having me again. We look forward to hopefully an interesting deployment this morning.
Okay, good morning, audience. And then I'd like to introduce a second very interesting case. This is a 79-year-old male admitted with dyspnea on exertion. Actually, he had a history of core valve implantation at 4 years ago, 31 millimeter core valve at that time. The recently echo showed that the severe eccentric paravalvular regurgitation with the moderate elevated dysfunction was found. Next. Age is 79, STS score is 2.7. Next. Echo showed that severe eccentric aortic paravalvular regurgitation. Ejection fraction is 40. HKG is LVBB. Next. Next. This is the aortogram immediately after the valve implantation, core valve 31. Looks like moderate paravalvular leakage. So during the four years, the patient didn't complain of dyspnea, but recently he suffered from the dyspnea on exertion. Next. Aorta is good. Next. The puncture site is good. Right iliac approach 7.0. Next. So this is a CT evaluation. Core valve narrowest part parameters. Short diameter is 23.5. Long diameter is 25.9. Mean diameter is 24.7. Perimeters driven diameter is 24.5. Perimeter was 77.1. Next. Left coronary height is high. Right coronary height high. At this point, the left coronary cuspid side, the core valve is too deep implantation. You can see. Next. This is the best fluoroscope view. Next. It's done. So do you have any comment or question about the patient history and current status?
So Dr. Ahn, this is Dr. Grube from Seoul National University. Good morning.
Good morning.
So as you mentioned, that the position is a little bit deep.
Yeah.
So is there any possibility of supraskirtal regurgitation at the time of implantation?
Yes, maybe. But after implantation, the echo showed that moderate paravalvular leakage. So at that time, we didn't correct this moderate paravalvular leakage. So patient no symptom for 4 years. So, but recently symptom developed. So we decided to correct the paravalvular leakage, severe paravalvular leakage.
So Dr. Ahn, do you have the echo to show us? Is the leak sort of circumferential and not due to any bulky leaflets on one side, anything like that?
What you said is all very relevant, obviously. Today, we would have not left it this way. We know that was 4 years ago. And it was a 31 millimeter valve. And you can see the 31 millimeter just slipped exactly where you don't want to have it. You know, it's above the shoulder. And you don't take advantage of the skirt. Remember, the skirt is 12 millimeter. And the leak is around it because it's simply too deep. It's a core valve that's too deep. There's nothing that you can argue, discuss. That has to be corrected. We would have probably corrected it now. In today's time, we would have probably corrected earlier, but that was 4 years ago. And now we correct this because the patient has gotten worse. And that's what the target is today with another core valve implant. That's probably what you would do in today's world, actually, and don't let the patient go out with moderate or even more regurg. And if we look at the valve-in-valve situation here, normally it's not so challenging. The only challenge, I would think, is the position of the second valve. Traditionally, you get confused with all the wires and all the frames. So it is very important that the initial position is selected correctly, and that's the only thing actually that you have to concentrate on, that the valve doesn't move up or down, and the valve doesn't slip because metal against metal. That's the good thing, that it doesn't go up, it doesn't go down. Keep that position and then deploy, and hopefully take advantage of a better position. The question then is, should we take a 31 or 29? And you can argue about a 29 and a 31. Considering the constraint and the perimeter of 77, I think there's a point that you could choose a 29. Remember, the 29 does have a shoulder. The 29 Evolute is not like the 29 Core Valve Classic. It does have a little bit of a shoulder, and in addition, it does have the advantage of being able to be repositioned, which in a valve-in-valve is kind of a nice feature to have, as we saw now with David's case. We hope that we don't need to do that, but in case we do, we can. And that's why we choose the 29 Evolute R in this case, hopefully abandoning the regurg.
Generally, you usually choose the same size of valve for the valve-in-valve?
Yes. Yeah, go ahead.
Is this valve is pretty low, right? I don't think a patient has a pacemaker. There's any increased risk of the pacemaker AV block or put a second valve in this kind of situation?
That's one of the good things, James, that you don't have to worry about the pacemaker. That's been taken care of by the previous implant. And we just
further stretch?
No, I don't think it's going to be the stretch. I think it's going to be the position. The leak is not because it's not stretching. The leak is because it's clearly too deep, and the flow is just going above the skirt, so you don't take advantage of the sealing. And that's what we hope to do with the 29 now.
Yeah.
The 34 was always very difficult to place, particularly when you couldn't recapture it with those shoulders. It always tended to slip down like this. So I think it's a good idea to go the 29.
Well, they don't have a 34 here.
Yes, right. We don't have.
They don't have a 34, and quite frankly, Darren, for me, the 34 is actually a better valve to deploy. We have less problems. Also, when you proctor the 34, with the 31, there was always a little bit of a problem proctoring because of the positioning. The 34 behaves a little bit differently, I think, but that's, of course, personal experience. So shall we go? Shall we move on while you can discuss, because we have another hopefully interesting case for you guys. And because Dr. Ahn is really the expert in positioning, we've changed position. I'm the servant, and I serve him this morning. But it's always my privilege to work with him and the team here, I have to say. It's really great, and I feel very comfortable.
Eberhard, you pointed out that sometimes with all these frames, especially if they're not completely aligned, there's so many different lines, is quite confusing to put where to put it. Sort of crisscrossing, and you don't have a pigtail in the non-coronary sinus. So it's a bit of a challenge just to keeping the eye sort of straight to where you want to keep it.
Exactly right, Alan, exactly right. So that's why the other thing that's very important that I want to point out is that when you wire, make sure the wire went in smoothly and doesn't go through the struts, because that is not a good thing, and you have to start all over again. but Dr. Ahn did that. He checked it, and it was good. So obviously, the valve is different. I'd like to do the positioning in a magnification because honestly, that's the most important part. Here, when we look at the position, we have a freeze frame up. And can we just inject for you guys so you see? I think the position is good.
Injection.
So that's a very good way to start. The difficulty here is, as you can see, the position of the previous valve is different than the actual valve. And so he has to concentrate on the non-coronary side in order to make sure that the valve can tilt once it's going to be deployed. And that's why I think it's nice to have the 29. Shall we start?
Yes.
So I go...
Would you like the pacing during the
No. This is much easier to do. The valve doesn't move. The metal in metal is not the problem. I just like to do a little bit more injections to make sure that because we don't have a reference.
Test.
Excellent. And then what you have to do is you look up at the upper part. That's really the part where you can see how high or whether the valve is higher or not.
I like, Eberhard, your way of turning, that you turn and take your hand off, and I think really takes some of the sort of taking a break in between, so letting the sheath come up gradually, and also for you to take a little sort of breather to see, how things are, rather than just keep turning.
Yeah, I take that. I didn't know actually. I look at the frame, so I didn't know that you were seeing this. Can you inject one more, please? Good. Are you okay, Dr. Ahn?
Okay.
See, once the valve expands, then basically you're lost. Then there's no way to determine the height and the depth and everything. Okay, can you do one more because now it starts flaring?
Yes.
One more injection.
Okay, I think it's good.
Yeah, but don't let it go further down.
Yes, I know.
Actually,
Push it away.
one more. Yeah, push the wire exactly.
Okay.
So you can see you start to lose it once it...
No.
Yeah.
No. Okay, so. Okay. Yep. Can we inject again?
Inject. Test.
Perfect. Hold on.
Okay, hold on.
Inject. Yeah, don't let
Okay.
it go down,
Yeah.
because
I know.
Can you not fluor? Can you film? Can you make a movie? Because the resolution is better.
Test.
No, it's not injection. It's filming.
Cine.
Cine. See, you're too deep.
Yes, I know.
So you can see how hard it is to see the mesh on mesh.
Yeah, that's the point. That's okay. That's okay. We're fine. But see, the cine is a little bit better as far as the resolution is concerned.
It's a more coaxial position. That was
Yeah, that's
better.
good. That was good. But that was
And-
actually stuck.
In certain ways, if the size right, putting a S3 is not a little easier actually, because you just have one dot where you want to be, and just
Yeah.
I know that you want to retrieve, but at the same time,
The advantage of the
This is hard.
retrieval is clear. You know, you can really take the time to finesse this and get it right with a retrievable valve.
Yeah.
And with a non-retrievable core
Yes,
valve like
480.
what this was
That's fine.
originally,
Yeah.
when it jumps forward, that's it.
Yeah.
You know.
Yeah.
Very good.
Everyone thinks an S3 would be
Very
very
nice.
simple.
Yes. I
Very
think
nice.
yes,
It's nice.
okay.
It's good.
어떤 부분을 더 이렇게 리드가 뭘 조금 더 잘했으면 좋겠다 이런 게 피드백을 주시면 그쪽으로 좀 더 할 건데.
Okay.
That looks good.
I think it's good. I think it's good.
Dr. Ahn thinks it's good.
No. Yeah.
So the key will be the echo, right?
Yeah, the echo or the. Can we just do an injection?
Yes. Yeah.
Okay. I think we should deploy. Actually, I think it's good.
Yeah.
Are you guys okay with it? Okay. I
Do we
hear.
have
I hear a
echo?
loud and distinct yes. So we deploy, right?
Okay.
Okay. Now we can take the magnification off and take the.
한 개 더. Wire, please. Okay. Ready. One more magnification.
So, diastolic pressure went up from 44 to 70 now, which is always a good sign. I hope you agree.
Okay, ready?
Are you guys still with us?
One more.
Yeah, the hemodynamics look great. I mean, we're waiting with bated breath to see if there's any residual regurgitation. With the wire across, it's going to be a little hard, but it looks mostly valvular there. But
Okay.
I think this sort of situation, toe is very good, or transthoracic echo to give you some, hint that you've got it right.
So now we're going to take everything out.
Yeah.
Then the question, and it's mild now with the stiff wire in there. I would be okay to leave it.
Would you
but
propose
we
dilate?
can see. Are we out? No, not yet.
Eberhard, would you choose a Pro if you were at home for this?
Good question, Alan. That's actually what we're trying to find out now. In which cases shall we use the Pro and in which the Evolute R? To be honest, I would probably not use the Pro here because normally, I didn't want to say it beforehand because you don't want to set the bar too high, but normally a valve-in-valve procedure with regular valves does give you a good result. So you don't need the extra skirt. If you position it right, then I think you're going to be okay. I would use the Evolute Pro, at least for the time being, in cases where you would expect by screening, a leak, particularly in the calcification situations. Otherwise, I would probably stay with the Pro. I don't know what the situation is pricing-wise, whether you have to pay a premium. So we just got the CE mark, I don't know, a couple of weeks ago, 4 weeks ago or something. So we're testing that. But actually, I'm very happy with, the pressure 150 over 73. Shall we exchange to a pigtail? Is that okay?
No,
Or
Can I
do you-
measure the AR
How about
index
the echo?
here?
And then, because I want to make sure that everybody feels good and that we did the right thing.
Yeah.
You can
know-
see at the top of the frame, you're definitely 3 millimeters higher.
Yeah, see the actual frame on the non-coronary was 8 to 9, and on the other was kind of 11-ish. And now if you get it a little bit higher, like 3-4 millimeters higher, then you are where you would actually like to be.
Do you think that for this kind of situation, have a T is better for the post-op assessment?
Well,
Any advantage
yeah.
to put a T down?
Yeah, we normally we don't use TE anymore in our setting. I mean, we use TEE when we have a problem for assessment.
So look at the echo, show the most regurgitation is coming from the valvula.
Yeah, from the wire.
Yeah,
Can we exchange?
Okay.
Or pull?
I just pull up.
Yeah, but if you pull, there's no way to do anything now because he's a little bit optimistic now.
Yes.
I would be a little bit more careful. If you do because now crossing 2 frames is a little bit more challenging if you want to.
Ready?
Yeah. Yeah, that's mild.
Trace,
Yeah, that's a trace. So that's good. Resolve the problem, 3-4 millimeters up. He's okay, but you know, in general, I would not pull the wire until you're really definitely clear that you don't post-dilate. But this, I think, is very acceptable, and I think we can leave it at that because my understanding is that there's another case, which takes probably more time, more challenging. I wanted to thank the team here. I wanted to thank you guys over there. I see you back at the meeting, and thanks for being with us this morning.
Thank you,
Bye-bye.
Eberhard.